Good morning, dear colleagues and friends. First of all, I would like to thank the organizers for inviting me to this very important African event, academic event about palliative care. Today, we will be talking about a very interesting topic, the reality and challenges of palliative care in Latin America, which could be a region that is geographically distant, but besides that, we have a lot of things in common, or many things in common with the African continent. Perhaps the challenges are very similar, the opportunities too, and mainly the hope for a better future in this aspect. So please allow me to share my presentation. Share screen. Great. Well, as I said, the title, this presentation is titled Reality and Challenges of Palliative Care in Latin America in the Pandemic Context. So, first of all, we must have had this question or a similar question about why Latin America is, or these regions, the African continent, if you want, or Latin America, in my case, are lagging behind in the development of policies about palliative care. Uh, Despite of all the evidence that, medically speaking, is undeniable, we know that there is a very strong evidence, but why, in despite of this evidence, we are lagging behind? Well, maybe we don't have a clear answer to this question because it could be that we're not asking the right questions. In this case, we should think a little bit more like the decision makers than like caregivers. And if we start thinking under that logic, maybe the real questions could be about palliative care, not in the medical aspect, but in the economical, in the policy aspect. Is it necessary for my population? Is it viable? Is it sustainable? It's a very important question. Is it the response to our problems, current problems and future demands? Is it cost efficient? This is a very important and crucial question. Do they improve the quality of and coverage? Impact. What will be the impact of this investment in this policy? So we have to make a context analysis that goes beyond the medical aspects, which, as I said, are undeniable in its validity. But the context is something that we will have to analyze during this presentation. So, mortality and epidemiological transition. The epidemiological transition basically means this shift, this decline in mortality due to certain types of diseases, specifically communicable diseases, and also the changes in the profile of deaths by causes, as I said, communicable to non-communicable, and the age group. Population is getting older and older every time, and that implicates a different type of demand. These patients will be increasingly older and will be suffering more and more frequently of non-communicable diseases. They will be needing symptom control, supportive care, and quality of life. That's palliative care. But right now, our systems are focused in the curative aspect. Basically, not only, of course, but basically, they have a curative approach. So to respond to this new type of demand, not so new because it's taking place as we speak, a different approach in this offer is mandatory. Now, to explain this in a more graphic way, we are showing here this graphic that shows this graphically the epidemiological and demographic transition, in which we see that the life expectancy at birth has increased progressively during the last 60 or 50 years. This is a curve for Latin America. This is a curve for Africa. We can see that in the 50s, the life expectancy in our regions was much, much inferior to the ones observed in European countries or in North America. Perhaps that's why they already have more developed healthcare systems oriented to palliative care, because they have felt this need decades before. Nowadays, Latin America, the life expectancy is very close to European levels, and it will be at European levels in less than a generation time. As I said, that has implications on the kind of offer and demand that healthcare systems will provide and face. Now, continuing with this epidemiologic transition, we see here the major causes of death by age group. Oh, sorry, by cause of death. There's a mistake. Here we see that non-communicable diseases count for more than 70% of causes of death worldwide. So older population, non-communicable diseases, basically. Of course, this can change depending on the area of the world that we look at. Perhaps Africa still is at an early stage of this transition, in which you still have a high demand of attention, of palliative care related to communicable diseases and younger age. But that will also change in time. Now, these graphics are very important. This group of graphics shows us the population pyramid, which is the population pyramid is a representation of the population by age and gender in a given point of time. Now, this pyramid can explain the phenomenon of sustainability. This offer of health has to be sustainable. Palliative care has to be sustainable as any kind of health offer. It depends partially in this distribution. In the 80s, for example, we have a population pyramid with a wide base, a small apex, and an age of working population or economically active population, which are not synonyms, but this is the group of people that with their work sustains and where their taxes and their payments sustain a pension system, a healthcare system that will take care of them in the future. At least that's in theory. Now, look at this pyramid in nowadays, 2020s. The base is getting narrow and the apex bigger. And the population in age of working, or the economically active population, is becoming smaller and smaller gradually. And look what will happen in the 2050s. These are projections. And you see that the base is even smaller and the apex even bigger, with the age of working population, and inside of this group, the economically active population decreasing progressively. That implicates a threat for sustainability. So now we have all these situations, the transition, demographic and epidemiological, this shift on the kind of demand, this distribution of population, age of working population that is decreasing, so it threatens the sustainability of any healthcare system. Besides that, COVID struck. In Latin America and the Caribbean live almost 9% of world's population, but by February 2022, it had already accounted for more than 66 million infections, 15% of the global total, and 1.65 million deaths, almost 30% of the global total. If we consider that in Latin America live less than 10% of the world's population, and they have had almost 30% of deaths, you can see that that is a very, very bad ratio. Now, the pandemic exposed weaknesses that made it very difficult to give a solid response, and solid and rapid response, and the displacements of budgets and resources were evident that delayed the palliative care agenda even more. These are, here we see how COVID-19 struck in Latin America in numbers. We can see that the average in Latin America per 1,000 population was 2.5 deaths. Peru has the sad honor of being #1 in deaths per population with 6.3 per 1,000. Brazil follows in a distant 3.03 per 1,000, United States 2.6 per 1,000, and Africa, well, it's not part of the region, but I consider it important to mention it, 0.18 deaths per 1,000. Now, here we see how healthcare systems were struck. How services were disrupted. And we can see the disruption was, in some cases, in some countries, bigger than 50% of their capacity in some types of services. This had a huge impact in the offer of healthcare services, palliative care included. Now, here we see how the patient was affected and couldn't be able to receive medical attention. Here we see, well, reasons that are directly linked to the pandemic, the fear of being infected. But if you see the other elements of this equation, if you want to call it, there are structural problems that have been there before the pandemic, have been there during the pandemic, and will be there after the pandemic. So a systemic approach that includes social aspects, economical aspects are very important. So what to do then without this context, so complicated? Policies. Policies are mandatory and fundamental because without them, we could not be able to articulate efforts, and any effort, no matter how big it is, will be fragmented, segmented, and its impact will be much, much smaller than in a scenario where there is a clear policy. So to conclude, we can say that, well, Latin America was one of the regions that was worstly hit. That's evident by the numbers. And it's essential to develop policies in palliative care. We have to guarantee universal coverage and access. These policies must consider the interdependence of health, social, economic, and even political dimensions, and a strategy that tackles a structural change. Now, a public health approach is mandatory, and we have to emphasize cost efficiency aspects. We have to be aware of these elements. Our arguments could not be only medical, only clinical. They are important, they're fundamental, but not enough when talking about policy making. The real battle is also at that level, dear colleagues. So the challenge is raised. Colleagues, the challenge is here and now, and we are the ones called to face it. Thank you very much, doctors, colleagues. It's been a pleasure.